Okay, bear with me. My animals are all in here with me, so if you hear any purring or barking, please excuse them. They don't have very good manners. Just to review from the previous lecture, coagulative equals structure preserved, nuclei gone. Liquefactive is structure gone, tissue melted, and brain is always liquefactive. Gangrenous necrosis is one of those terms that sounds very official, but it's actually more of a clinical descriptor than a true histologic category. This is not a distinct cellular mechanism. It's a way of describing extensive tissue death, usually in a very visible, very dramatic way. Most of the time, gangrene starts as coagulative necrosis due to severe ischemia. Basically, the tissue is starved of blood long enough that it can't recover. Where do we usually see this? Think extremities, so toes, feet, and fingers. The places furthest from the heart and most vulnerable to poor circulation. Whether it stays relatively contained or becomes a bigger problem depends on infection. And once infection enters the picture, inflammation and tissue destruction ramp up fast. So gangrene is really the pathology version of this started bad and then it gets worse. These images drive home why gangrene is often discussed clinically before it's ever discussed microscopically. Again, we're talking about extremities, where blood supply is already more fragile. Once ischemia sets in, tissue dies, and then bacteria may take advantage of that dead tissue. You'll notice that progression depends on whether infection is present. Dry gangrene equals ischemia alone, and wet gangrene is ischemia plus bacteria. Histotech reality check here. You don't often get pristine histology from gangrenous tissue. By the time it reaches the lab, the architecture is usually severely compromised, which is exactly the point. This slide is all about contrast. Let's start with dry gangrene. It's caused by ischemia only. Tissues become dry, blackened, and mummified. Progression is slow. There's minimal inflammation. Think of dry gangrene like a plant that wasn't watered. It shrivels, darkens, and stops changing much. Now, wet gangrene. Ischemia plus bacterial infection. There's rapid tissue breakdown, significant inflammation. The tissue becomes swollen, soft, and oftentimes foul smelling. Wet gangrene is more like leaving food out in the heat. Bacteria show up, enzymes get involved, and things fall apart fast. So again, dry equals ischemia only. Wet equals ischemia plus infection plus inflammation. Caseous necrosis is one of the easiest patterns to recognize once you've seen it, mostly because it has a very memorable description. The name comes from caseous, meaning cheese, and yes, it really does look soft. It's white, yellow, and crumbly. Unlike coagulative necrosis, tissue architecture is not preserved here. Instead, you get an acellular necrotic center surrounded by inflammatory cells. Microscopically, this necrotic center is kind of a no man's land. No nuclei, no recognizable cells, just granular debris. And surrounding it, macrophages, lymphocytes, and other inflammatory cells forming a granuloma. Classic association is tuberculosis. When you see caseous necrosis, TB should immediately enter your mental chat. This slide brings caseous necrosis to life, but grossly and microscopically. On the gross image, that pale, crumbly material in the center, that's classic caseation. Microscopically, notice the organization. Central caseous necrosis, surrounded epiloidal macrophages, Langhans giant cells, and peripheral lymphocytes. This organized inflammatory structure is a granuloma, which is the body's attempt to wall off something it can't easily eliminate. A histotech tidbit: granulomas are incredibly satisfying to identify on H&E because the architecture tells a story. Center of destruction, surrounded by immune defense. And just to reinforce, caseous necrosis equals granulomas plus TB until proven otherwise. So just a quick wrap up. Gangrene is the clinical term for extensive tissue death. Dry gangrene is ischemia only. Wet gangrene is ischemia plus infection. And then caseous necrosis is a cheese-like center plus granulomas plus TB. Necrosis is exactly what it sounds like, death of adipose tissue. But the why is what makes it interesting. This most commonly happens due to trauma, especially in breast tissue or as a complication of acute pancreatitis. In pancreatitis, digestive enzymes escape and start doing what they do best, digesting things that absolutely should not. Lipases break down triglyceride inside fat cells, and once that process starts, the fat cells don't stand a chance. Clinically, fat necrosis can be tricky because it often presents as a firm lump. In the breast, this can mimic malignancy, which is why pathology matters so much here. Skin over the area may show redness, bruising, dimpling, or tenderness, but sometimes it's completely painless, which makes it even sneakier. This slide shows you what fat necrosis looks like once chemistry gets involved. When fat cells rupture, free fatty acids are released. These bind with calcium and form chalky white deposits, a process called saponification. Yes, this is literally soap formation. Pathology is chemistry with better lighting. Grossly, you'll see firm, white, gritty areas. Microscopically, you'll notice shadowy outlines of fat cells, inflammatory infiltrates, areas of calcification. And a little histotech tip here, even though adipocytes normally look empty on H&E, fat necrosis has a very different ghosted appearance. Once you've seen it, you will never forget it. Fibrinoid necrosis is a very specific pattern, and it only shows up in one place, blood vessel walls. Here the normal vessel structure is lost and replaced by bright pink fibrin-like material. That color is your biggest clue on H&E. This type of necrosis is always linked to immune-mediated injury. Think vasculitis, severe hypertension, or autoimmune disease. When vessel walls are damaged, they can't contain blood properly, which leads to clinical signs like nosebleeds, bleeding gums, bruising, organ hemorrhage. So fibrinoid necrosis is less about tissue architecture and more about vascular integrity failing spectacularly. This slide zooms in on what fibrinoid necrosis actually looks like under the microscope. Grossly, you may just see bleeding or hemorrhage, but microscopically, it's much more dramatic. The normal layers of the vessel wall are replaced by intensely eosinophilic material. This is plasma proteins and immune complexes leaking into the wall. Pathogenesis-wise, this is an immune problem. Immune complexes deposit, the plasma proteins leak, inflammation follows, and the vessel wall undergoes necrosis. A reminder as a histotech, when you see a vessel glowing hot pink on H&E and it doesn't look like collagen, think fibrinoid necrosis. And now we pivot because necrosis and injury naturally lead us into inflammation. Inflammation is a protective response. Its job is to eliminate the cause of injury, remove damaged tissue, and start the repair process. It can be triggered by a lot of things: tissue damage, ischemia, toxins, or immune reactions. The key player here is the blood vessel. Vessels change in ways that allow immune cells to leave circulation and enter the tissue. This whole process is driven by chemical mediators, such as histamine, cytokines, prostaglandins, Basically, molecular text messaging saying, hey, something's wrong over here. And here's the balance. Controlled inflammation equals being helpful. Excessive or prolonged inflammation is harmful. Inflammation is like calling for backup. Great when it's appropriate, a problem when it doesn't know when to stand down. So let's recap just a little bit. Fat necrosis is trauma or pancreatitis and saponification. Fibrinoid necrosis is immune injury to vessel walls. And then we've talked about inflammation, right? So it's protective, but only when regulated. All right, this slide is one of those, you already know this, but now we're naming it properly moments. These are the 5 cardinal signs of inflammation, and they've been around since ancient medicine, literally Roman era observations that still hold up today. We have pain, also called dolor. We have warmth, also known as calor. We have redness, also known as rubor, swelling, tumor, or loss of function, which is functio lysa. Now here's the important part. These aren't random. They all trace back to vascular changes. Redness and warmth come from increased blood flow. Swelling comes from fluid leaking out of vessels. Pain happens because swelling and chemical mediators irritate nerve endings. And loss of function, well, that's basically your body saying, hey, don't use that right now. I'm fixing it. A histotech tie-in, when you see edema, dilated vessels, and inflammatory infiltrates on H&E, you're literally seeing these 5 signs translated into histology. If a question asks why a sign occurs, the answer almost always starts with vascular changes. This slide is a favorite exam comparison, so let's make it painless. Acute inflammation is fast, short-lived, usually physiologic. It's dominated by neutrophils. And think of acute inflammation like a fire alarm. Something happens, alarms go off, help arrives quickly, problem gets handled, and ideally everyone goes home. Chronic inflammation, we have slow onset. It's long lasting, usually for months to years. It's always pathologic. It's dominated by macrophages and T lymphocytes. Chronic inflammation is more like a smoldering fire that never quite goes out. It keeps damaging tissue over time. And yes, acute inflammation can become chronic if the stimulus isn't removed, or there's repeated injury, or the immune response stays activated. If you see lots of neutrophils, think acute. If you see macrophages, lymphocytes, and fibrosis, think chronic. Neutrophils sprint, macrophages move in and unpack. Now let's zoom in on acute inflammation because this is the foundation for everything that follows. Acute inflammation has 3 major components: vascular changes, cellular changes, and chemical mediators. In vascular changes, the blood vessels dilate and become leaky. This is on purpose. Cellular changes, we have white blood cells, especially neutrophils, that are recruited to the site of injury. And then mediators, these are chemical signals, things like histamine, prostaglandins, cytokines that coordinate this whole response. Think of acute inflammation like a group text gone wild. Someone gets injured, chemical mediators send the message, blood vessels open the gates, and neutrophils show up first, ready to fight. When tissue is inflamed acutely, fixation matters. Poorly fixed tissue can exaggerate edema and make inflammation look worse than it actually is. This slide explains why inflammation looks the way it does. The very first thing that happens is a brief vasoconstriction. We're talking seconds. And then vasodilation kicks in. Once vessels dilate, blood flow increases, which leads to redness and warmth. Then vessel walls become leaky, which is our plasma proteins and fluid escaping. That fluid accumulation becomes exudate, which leads to swelling. A key distinction here, and we'll talk about this more later in the slides. Exudate is protein-rich inflammatory fluid, and transudate is low-protein fluid, usually from pressure issues, not inflammation. So a Histotec pearl here is that pale, wispy pink background you see on H&E during inflammation. That's protein-rich exudate sitting in the tissue. So red, hot, swollen tissue equals leaky, dilated vessels. This is the step-by-step choreography of how immune cells leave the bloodstream and enter tissue. And yes, this sequence really does matter. We have step 1, which is margination. This is where blood flows slow and leukocytes move towards the vessel wall. Step 2 is rolling. Cells loosely roll along the endothelium like bumper cars. Step 3, adhesion. They stick firmly to the vessel wall. Step 4, diapetus or transmigration. Neutrophils squeeze between endothelial cells. No vessel rupture required. Step 5, chemotaxis. This is where cells follow chemical signals straight to the injury site. Once there, neutrophils phagocytose, debris, bacteria, and damaged cells. This is basically TSA for immune cells. Slow down, show ID, go through security, and follow signs to the problem area. When you see neutrophils clustered around necrotic tissue, vessels, or bacteria, you're looking at successful recruitment. If you see the word chemotaxis, think directed movement towards injury signals, not random wandering. This slide is the big picture roadmap for inflammatory mediators, and I want to say this up front. You are not expected to memorize every single mediator on this diagram. What is important is understanding where they come from and what they do. Inflammatory mediators fall into two major buckets. The first one, cell-derived mediators. These come from mast cells, neutrophils, macrophages, and endothelial cells. Some are preformed, like histamine, meaning they're already made and just waiting to be released. Others are newly synthesized, like prostaglandins and leukotrienes, which are made on demand. The second one is plasma protein-derived mediators. These are made mostly by the liver, circulate in the blood in an inactive form until they're needed. So things like complement proteins, the kinin system components, and coagulation factors. This entire slide explains why inflamed tissue looks the way it does on H&E. Edema, hyperemia, and neutrophil infiltration. So key takeaway from this slide is mediators are the chemical middlemen between injury and what you see under the microscope. Now we're going to break the mediators down into the ones you actually need to recognize by name. We have histamine. They are released from mast cells, basophils, and platelets. These causes vasodilation and increased vascular permeability. Think of histamine as the door opener. It opens vessels fast and early. Prostaglandins, made from arachidonic acid, cause vasodilation, pain, and fever. This is why NSAIDs work. They block prostaglandin synthesis. Leukotrienes, also arachidonic acid derivatives, even more potent than prostaglandins. They promote vascular permeability and leukocyte recruitment. Leukotrienes are like prostaglandins with extra attitude. Cytokines such as TNF and IL-1, these are produced by macrophages and endothelial cells. They promote fever, leukocyte adhesion, and endothelial activation. If you see TNF or IL-1, think systemic effects. So histamine is early and fast, prostaglandins is pain and fever, leukotrienes is sustained inflammation. The chemokines are basically the GPS system for immune cells. They direct leukocytes towards the injury site. They control chemotaxis, meaning directed movement, not random wandering. Chemokines don't activate cells, they tell them where to go. Then we have the complement system. This is part of the innate immunity and works like an amplifier for inflammation. Key components to remember here is C3A and C5A. These trigger mast cell activation and promote chemotaxis. We have C3b, which acts as an opsonin. It makes pathogens easier for neutrophils and macrophages to eat. So C3b is better bite for phagocytes. Then we have nitric oxide. Nitric oxide is produced by endothelial cells and macrophages. It causes vasodilation and has some antimicrobial effects. Yes, nitric oxide is a gas, one of the few gaseous signaling molecules in the body. Nitric oxide helps explain increased blood flow during inflammation. And then we have reactive oxygen species, or ROS. ROS are produced mainly by neutrophils and macrophages. They kill bacteria and pathogens and can also damage host tissue if overproduced. So ROS are like using bleach. They're great for killing germs, but terrible if you spill it everywhere. A Histotec pearl on this slide is excess ROS contributes to tissue injury you'll see on H&E, especially in severe inflammation. So big picture wrap up here is inflammatory mediators don't work alone, they work in teams. Some open vessels, some recruit cells, some kill pathogens, and some cause collateral damage. That balance determines whether inflammation helps or harms. This slide is chronic inflammation in one sentence, damage and repair happening at the same time and neither one winning. Chronic inflammation happens when injury persists, the infection isn't cleared, or the immune system won't shut off. Instead of neutrophils, we now see a mixed infiltrate dominated by macrophages, lymphocytes, and plasma cells. At the same time, tissue destruction continues, fibrosis develops, and new blood vessels form, which is also known as angiogenesis. If you see fibrosis plus inflammatory cells in the same section, you're almost always dealing with chronic inflammation. So chronic inflammation equals long-term damage with attempted repair. This slide answers a very practical question. Why does inflammation turn off? Chronic inflammation can be driven by unresolved trauma or infection, poor diet and metabolic stress, smoking and alcohol, chronic stress, poor sleep habits, or hormonal imbalances. And here's the important clinical concept. These drivers constantly stimulate cytokine release, keeping the immune system in a low-grade activated state. The symptoms you see, fatigue, body pain, GI issues, and mood changes, are systemic effects of chronic inflammation, not just local tissue problems. This is why chronic inflammation is linked to diseases like atherosclerosis, autoimmune disease, cancer, or degenerative joint disease. Chronic inflammation isn't loud, it's just persistent. This is a special subtype of chronic inflammation, and it shows up a lot on exams, so let's slow it down a little bit. A granuloma is a small, organized collection of macrophages formed when the immune system can't eliminate a stimulus. The key players here, activated macrophages, CD4 plus helper T cells. Here's the sequence. Macrophage ingests the antigen. They present it to the CD4 positive T cells. T cells release the IFN and IL-2. Macrophages become highly activated. Inflammatory cells accumulate and wall off the problem. There are two types, caseating granulomas, which have central necrosis, cheese-like appearance, classic example being tuberculosis. And then we have non-caseating granulomas, so no central necrosis. This is seen in sarcoidosis, Crohn's disease, and foreign body reactions. A Histotec pearl on this slide is granulomas. Granulomas often have a tight nodular architecture. Once you see a few, they become very recognizable. Granulomas are the immune system's way of saying, I can't kill this, but I can contain it. All right, let's continue talking about granulomas, which are basically, again, the body's way saying, I don't know how to get rid of this, so I'm going to wall it off. On gross exam, granulomas often appear as firm nodular lesion. They're commonly yellow-white, and unlike acute inflammation, these lesions tend to persist rather than resolve quickly. Over time, they can distort normal organ architecture, which matters both clinically and histologically. Now, microscopically. This is where histotech eyes light up. Granulomas are rounded aggregates of epithelioid macrophages. These are activated macrophages that start looking more epithelial than phagocytic. You'll also see multinucleated giant cells, and there are two classic types of giant cells to remember. There's the Langhans giant cells, which nuclei are arranged around the periphery, so think horseshoe. And then there's foreign body giant cells, where the nuclei are scattered randomly. Surrounding the granuloma, there's typically a rim of lymphocytes reflecting chronic immune activation. Sometimes there's central necrosis. So caseating granulomas, think tuberculosis. Non-caseating granulomas, think sarcoidosis. If you see epithelioid macrophages and giant cells in a lymphocyte rim, your brain should immediately say, I'm looking at a granuloma. This slide is one of those small words, big meaning pathology concepts, transudate versus exudate. A transudate is a low protein cell core fluid. It is not caused by inflammation. Instead, it results from hydrostatic or oncotic pressure imbalances. Classic causes include congestive heart failure, liver disease, or kidney disease. So if there's fluid but no inflammatory response, think transudate. An exudate, on the other hand, is caused by inflammation. Inflammatory mediators increase vascular permeability, allowing protein in cells to leak out. Two common types of this type is serous exudate, which is clear, low cell fluid, like a blister. And then there's fibrinous exudate, which is high protein fibrin strands with lots of cells. So T equals transudate, which equals trouble with pressure, and E is exudate with endothelial gaps from inflammation. This distinction shows up constantly in pathology reports, so don't be surprised if it also shows up once on your exams. Now let's switch gears to patterns of soft tissue infection, starting with abscesses. An abscess is a localized, walled-off collection of pus inside tissue. The key idea here is localization. The body is trying to contain the infection. So examples include boils or furuncles, comedones, meaning blackheads and whiteheads, or pimples, also referred to as papules and pustules. And then there's paronychia, which is infection around the nail fold. And empyema, however, is different. This occurs when pus fills a body cavity, not tissue. For example, the pleural space around the lung. So an abscess equals pus in tissue, and an empyema is pus in a space. That distinction is very important for diagnosis, treatment, and specimen handling. This is a very high-yield comparison, both clinically and pathologically. Cellulitis is a non-localized soft tissue infection. There's no discrete pus collection. Instead, you get a diffuse acute inflammatory response involving the skin and the subcute. Necrotizing fasciitis is much more dangerous. This is a rapidly spreading infection that tracks along facial planes, causing tissue necrosis. Without immediate surgical intervention, necrotizing fasciitis has a high mortality rate. Both conditions can progress to toxic shock syndrome, which is life-threatening and may involve severe respiratory distress, renal failure, and even multi-organ dysfunction. If you see rapid progression, severe pain, and tissue death, think necrotizing fasciitis, not cellulitis. Last up in this set are cellular accumulations. These are substances that build up inside or outside cells, often disrupting normal tissue function. We have hemosiderin. This is an iron storage pigment from hemoglobin breakdown. Histologically, it appears as gold-brown granules, especially after hemorrhage. Then we have fatty change, or also known as steatosis. This is abnormal triglyceride accumulation within cells, most commonly hepatocytes. You'll see clear vacuoles pushing the nucleus aside. Then this, we have adiposity. This refers to excess accumulation of adipose tissue, which is different from fatty change inside cells. Then we also have glycogen storage. Here you get excess intracellular glycogen, often giving cells a swollen, pale appearance. And amyloid. Amyloid is an abnormal extracellular protein deposit that disrupts tissue architecture and function. Special stains like Congo red help confirm it. Big takeaway, accumulations can be reversible or irreversible, and recognizing them histologically helps explain organ dysfunction. We're still hanging on out in the world of cellular clutter, the things cells shouldn't be hoarding but sometimes do anyway. So first up is hemosiderosis. This is iron accumulation without tissue damage. So think of it like extra storage bins in a garage. It's crowded, but nothing is broken yet. You often see this after repeated hemorrhage or transfusions. Next is calcification, and this is where students love to mix things up, so let's slow it down just a tiny bit. Dystrophic calcification happens in damaged or dead tissue, even when blood calcium levels are normal. So old scars, necrotic tumors, atherosclerotic plaques, that is calcium showing up uninvited. And then we have metastatic calcification. This happens in normal tissue, but the calcium levels in the blood are high. This is more of a systemic problem. So dystrophic is damaged tissue but normal calcium, and metastatic is normal tissue but high calcium. Then there's hemochromatosis, which is iron overload with tissue damage. This is no longer a storage issue. This is iron actively wrecking organs like the liver, pancreas, and heart. And finally, lipofuscin, the so-called wear and tear pigment. This is that fine golden brown junk that accumulates with aging. It's basically the cellular equivalent of mileage. A histotech tidbit here, lipofuscin is autofluorescent, which is cool scientifically, but annoying if you're doing fluorescent microscopy. Now we transition from injury and inflammation into something a little more hopeful, repair. Tissue repair is how the body restores structure and function after damage. Think of it as biological home renovation. There are two main ways this happens. Number one, regeneration. This is the ideal scenario. The damaged cells are replaced by the same type of cells, and everything looks and functions like it did before. No scar, no evidence anything ever happened. Tissues that are good at this include the epidermis, the GI epithelium, and bone marrow, or basically tissues that are used to high turnover. Number two is repair by fibrosis or scar formation. This happens when regeneration isn't possible, either because the tissue can't regenerate or the damage was too extensive. Instead of original tissue, the body lays down fibrous connective tissue. Regeneration and fibrosis often happen together, not separately. So yes, real life is messy and pathology reflects that. This slide is doing a lot of work visually, so let's walk through it together. When tissue is injured, the body asks one question: can I rebuild this exactly as it was? If yes, regeneration occurs. If the answer is no, then repair with scarring occurs. So our repair pathway, we have hemostasis, which stops the bleeding. Inflammation cleans up the debris and the pathogens. We have proliferation, where fibroblasts and granulation tissue move in. Then there's remodeling, which is scar tissue is refined over time. This is why scars initially look thick and pink and later flatten and fade. Then we have the regeneration pathway, which occurs when stem cells are available. Original tissue architecture is restored and no scar forms. Repair is patching drywall. Regeneration is replacing the whole wall like it was never damaged. Granulation tissue is highly vascular, so expect lots of capillaries and fibroblasts on H&Es. Now let's talk about how wounds are managed, because how a wound is treated absolutely affects how it heals. There's primary intention, where it's clean surgical wounds. Edges are brought together with sutures or staples. There's minimal inflammation and minimal scarring. This is your textbook surgical incision. Then there's secondary intention. These are wounds with significant tissue loss or contamination. These are often left open to heal from the bottom up. There's more granulation tissue, which equals more scarring. This is slower, but safer for dirty wounds. Then there's tertiary intention, initially left open due to contamination, closed later after repeated debridement. It's kind of a wait and see approach. Surgeons choose the healing strategy based on infection risk, not aesthetics. This slide answers the question, why do some wounds heal beautifully and others absolutely refuse to cooperate? First, virulence of the organism. Some pathogens are just better at destroying tissue than others. Not all infections are created equal. Advancing age. Healing slows with age. Fewer stem cells, slower cellular responses. This is biology, not failure. Poor nutrition. Protein and vitamin C are essential. No protein, no collagen. No vitamin C, we have poorly cross-linked collagen. Diabetes. Poor blood flow means nutrients don't reach the wound effectively. This is why diabetic ulcers are such a problem. And lastly, steroid therapy. Steroids blunt inflammation, which sounds good until you realize inflammation is necessary for cleanup and repair. So big picture takeaway here is healing requires blood flow, nutrients, immune cells, and time. Take away any of those and repair slows down. This is your official pause point. If something felt confusing, good. That means your brain was working. If something finally clicked, even better. Remember, as histotechnologists, you're not just identifying structures, you're interpreting processes over time. So ask questions, make connections, and don't worry about memorizing everything perfectly today. Understanding comes first, and then recall follows. If you have any questions, please feel free to email me or attend the Zoom office hours. Thanks.